And without further ado, welcome. Breast Cancer Management in North Carolina, updates for 2021 with Yara Abdou, MD. Next slide, please. Dr. Abdou specializes in the treatment of early stage and metastatic breast cancer. Her research focuses on the development of novel therapies to treat subtypes of breast cancer. She works closely with basic and translational scientists to study the breast tumor microenvironment and find ways to enhance treatment approaches by utilizing the immune system. In addition, her research also focuses on racial differences in tumor biology and immune microenvironments to better understand racial disparities and improve clinical outcomes in Black women with breast cancer. Dr. Abdou, welcome. We're so glad to have you here today.
Thank you, Tim.
What's one thing we should know about you outside of your professional bio?
That's an interesting question. I do have a little golden doodle. She's 15 pounds, and I love her to death.
Oh my gosh. How old is she?
She's 2 years old.
Oh, great. Well, good for you. And let's go on to the next slide, and we'll start to talk about poll everywhere. First question, as most of you know, is always kind of a softball. Breast cancer is the second most common cancer diagnosed in women in the U.S. True A, B, false. And again, all anonymous, so that'll pop up in just a minute. And next slide, please. And I'll read our disclosures. This activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Yara Abdou, MD, has no financial relationships with commercial interests as defined by the ACCME. And next slide, please. All right, so Dr. Abdou, let's take maybe 5 more seconds. Anyone who hasn't already responded to that. So breast cancer is the second most common cancer diagnosed in women in the United States. Dr. Abdou, how are they doing?
Hopefully in a second.
Okay. All right, and we'll give you a few more seconds. So take 10, 15 more seconds if you would. All right, how are they doing?
Pretty good.
Good. All right, and if you want to go ahead and advance it and take it away. So breast cancer management updates for 2021 with Yara Abdou, MD, Division of Oncology, University of North Carolina, UNC Lineberger Comprehensive Cancer Center in Chapel Hill.
Thank you, Tim. All right, so we'll start with some objectives. So today we're going to be talking about practical application of genomic assays in hormone-positive, HER2-negative breast cancer. We're going to talk about some CDK4/6 inhibitor updates in the metastatic and the adjuvant setting. And then I'm going to talk about treatment updates in early and metastatic HER2-positive disease. And last but not least, we're going to talk about new treatment options in triple-negative breast cancer. So I just want to start off reminding everyone that in the U.S., breast cancer remains the most commonly diagnosed female cancer, with more than 280,000 cases estimated this year. And it's the second most common cause of cancer death in women behind lung cancer. As a general rule, when cancer is found early, people do well, but when cancer is found late with a large burden of disease, people unfortunately do not do as well. With time, we started realizing that staging was not the only factor that determines survival. As you see here, a patient with stage 2, T2N0 breast cancer can have a 96% 5-year breast cancer specific survival if it belongs to the hormone-positive HER2-negative subgroup, but an 88% survival if it belongs to the triple-negative breast cancer subgroup. Similarly, in stage 4 disease, survival is drastically different based on subtype. Through the work of Chuck Baru at UNC and many others, we have evolved to recognize that there are multiple distinct molecular subtypes of breast cancer with Jivarian gene expression profiles. And based on these gene expression profiles, tumors are characterized into different subtypes such as luminal A, luminal B, HER2-positive, or basal-like. And through this knowledge, we began to answer the question of who really benefits from what kind of therapy. Additionally, these subtypes have prognostic value. So you can see that even across patients who have ER-positive breast cancer, patients with luminal A cancers have a much better prognosis than patients with luminal B subtype or basal-like subtype. So we've began incorporating these genomic assays in clinic to help us predict prognosis and manage our patients accordingly. So let's start by looking at updates in the hormone-positive breast cancer. We'll start off with a case. So Mrs. K is a 65-year-old woman with no prior comorbidities. She was found on screening mammogram to have a 1.5 centimeter left breast mass. This was biopsied and found to be invasive ductal carcinoma, grade 2, ER 90%, PR 90%, and HER2 negative by IHC. Her tumor was excised with negative margins. She had a final tumor size of 1.8 centimeter, and her sentinel lymph node biopsy showed 1 out of 2 sentinel lymph nodes that were positive for metastatic disease. She asks you, what's next, doc? Historically, in the not-so-distant past, all patients with tumors over 1 centimeter have been recommended to receive chemotherapy as it was associated with improved survival. This led to a lot of overtreatment in ER-positive breast cancer. So the question is, which ER-positive tumors really benefit from chemotherapy? So one of the ways in which we are personalizing cancer care in 2021 is to send these tumors for genomic assay testing, which can help us decide whether to give adjuvant chemotherapy in addition to endocrine therapy, or whether endocrine therapy alone is sufficient in some cases. Several predictive and prognostic genomic assays are used in clinic, including Oncotype DX, ProSignal, MammaPrint, EndoPredict, and BCI. I'm going to focus on Oncotype DX because it's one of the most common genomic assays, and we have a lot of prospective data in that regard. So Oncotype DX predicts benefits from chemo and prognosticates risk of distant recurrence. As we know, the 21 gene assays classifies patients into low, intermediate, and high-risk groups based on the scoring system. For the longest time, there was a controversy regarding the intermediate score and whether you actually see any benefit in this group of patients. Therefore, in 2018, Taylor X randomized these intermediate patients to receive chemo, endocrine therapy versus endocrine therapy alone. Analysis showed that the benefit from chemo in this intermediate risk group really depends on menopausal status. So in the postmenopausal patients over 50 years old, scores below 25 or below 26 do not really benefit from chemotherapy. Whereas patients under the age of 50, who are usually premenopausal, did have some benefit from chemotherapy. There was a 6.5% chemotherapy benefit if your score lays between 21 and 25, and a 1.6% benefit if the score is between 16 and 20. There was no chemotherapy benefit below the score of 16. So in practical application, in node-negative women, usually we do not give chemotherapy if scores are below 16 in premenopausal women. If it's between 16 and 20, we may consider chemotherapy after discussing risks and benefits with the patient. And if it's above 21, we usually recommend chemo plus endocrine therapy. In postmenopausal women, the only benefit of chemotherapy was seen with a risk score of 26 or higher. I just want to remind everyone that with every chemotherapy decision, we have to take into consideration patient comorbidities, preferences, and tumor characteristics. Moving to the most recent updates in genomic testing, which is data from RxPonder. Initially, all these genomic assays were studied extensively in lymph node negative patients and extrapolated retrospectively to patients with lymph node positive disease. This study was a much awaited study in lymph node positive patients, specifically 1 to 3 positive lymph nodes. This study presents the prospective analysis focusing on women with 1 to 3 positive lymph nodes, hormone positive, HER2 negative, who had an Oncotype DX recurrence score of 0 to 25. These patients were randomized prospectively to receive chemo plus endocrine therapy versus endocrine therapy alone. And when looking at invasive disease-free survival, stratified by menopausal status, we see that in the postmenopausal woman, there were no statistically significant differences in both groups. However, when we look at the premenopausal group, we do see a 5-year invasive disease-free survival absolute difference of 5.2%, favoring the chemotherapy plus endocrine therapy arm with a hazard ratio of 0.54. Looking more closely at the premenopausal group, we see that the differences in both treatment groups are even more impressive when stratified by risk score. So the higher your risk score, the higher is your absolute difference in 5-year IDFS. So back to our practical application. Now in the lymph node positive group of patients with 1 to 3 positive lymph nodes, really we're questioning the role of genomic assay in premenopausal women at this point, because it seems like the chemotherapy benefit was across all subgroup of patients. Whereas in the postmenopausal group, we can now comfortably say that we can omit chemo in patients with a risk score below 26. In patients with node-positive disease of 4 or more lymph nodes, usually the recommendation is chemotherapy with endocrine therapy. So back to our case, her tumor was sent for genomic testing. Her Oncotype DX score returned at 19. Based on recent data, what do you tell your patient? And just a reminder, this is a patient with 1 positive lymph node. She was postmenopausal. Her recurrence score is 19, and her tumor size was 1.8 centimeter. And let's just say she was no major comorbidities. Excellent. So we do proceed to endocrine therapy given her score is less than 26, indicating no benefit from chemotherapy in a postmenopausal woman with 1 to 3 positive lymph nodes. Let's move on to CDK4/6 inhibitor updates. So there are 3 FDA-approved CDK4/6 inhibitors in either the first-line or second-line setting in hormone-positive, HER2-negative breast cancer. And the approval was based on impressive progression-free survival across all groups with a hazard ratio of around 0.5. In the first-line setting, we usually combine CDK4/6 inhibitors with aromatase inhibitors, and in the second-line setting, we tend to combine them with fulvestrant. In ASCO 21, a few weeks ago, we saw data confirming that a consistent overall survival advantage for CDK4/6 inhibitors. Paloma-3 is the pivotal trial of fulvestrant plus minus palbociclib in women with hormone-positive, HER2-negative metastatic breast cancer who are progressing on prior endocrine therapy. MONALEESA-3 looked at fulvestrant plus minus ribociclib in the first and second-line setting. Interestingly, in Paloma-3, the prolonged overall survival benefit is particularly evident in patients with endocrine-sensitive disease and those without prior chemotherapy, in the advanced metastatic setting, a hypothesis generating finding that will probably not affect our clinical practice at this time. Looking at the Mona Lisa study, we see that the overall survival benefit was seen independent of therapy line and seen in both first-line and second-line settings. Additionally, in the Mona Lisa 3, there were consistent overall survival benefit observed across most subgroups, including patients with visceral disease and 3 or more metastatic sites. Furthermore, the Donna-1 study was presented at ASCO 21, where Dalpaciclib, a new CDK4/6 inhibitor, was evaluated with fulvestrant in patients who progressed on prior endocrine therapy. Here we see impressive improvement in progression-free survival in the Dalpaciclib arm with a hazard ratio of 0.42. Overall survival data is still immature at this time. However, these findings do support that Dalpaciclib plus fulvestrant could be a new treatment option in patients with hormone-positive, HER2-negative advanced breast cancer who relapsed or progressed on prior endocrine therapy. So what about CDK4/6 inhibitors in the adjuvant setting? This brings us to Monarchy, which is a phase 3 trial that evaluated the combination of CDK4/6 inhibitor abemaciclib in addition to standard endocrine therapy versus endocrine therapy alone among 5,637 patients with hormone-positive, HER2-negative, early breast cancer at high risk of early recurrence. And that was defined by patients with 4 or more positive lymph nodes or node-positive disease with histological grade 3 or tumor size of greater than or equal to 5 centimeters. There was a cohort 2 based on Ki-67 of more than or equal to 20% with node-positive disease. Their primary objective was invasive disease-free survival. The results showed that abemaciclib plus endocrine therapy in the adjuvant setting demonstrated superior IDFS versus endocrine therapy alone with absolute improvement of 3.5%. The benefit was seen across all different subgroups. Additionally, there was a clinically meaningful reduction in risk of developing distant metastases with an absolute reduction of 3.3% in the abemaciclib plus endocrine therapy arm. The overall survival is still immature at this time. If approved, abemaciclib added to standard adjuvant endocrine therapy could become a new standard of care for patients with hormone-positive, HER2-negative, high-risk early-stage breast cancer. So to summarize our updates from the hormone-positive breast cancer patients, data from the RX-Ponder trial are practice-changing and will allow postmenopausal women with 1 to 3 positive lymph nodes and a risk score of 0 to 25 to safely omit chemotherapy. There are 3 approved CDK4/6 inhibitors for hormone-positive, HER2-negative metastatic breast cancer with consistent overall survival improvement when added to fulvestrant in the first and second-line setting. Dalpaciclib is a potential new CDK4/6 inhibitor, and abemaciclib now has data in the adjuvant setting. Overall survival is still immature, and it's not yet FDA approved when we are waiting more updates on this drug. Moving on to HER2-positive disease. In the early stage, HER2-positive breast cancer, a lot has changed in the last decade, with several new therapeutic regimens that have augmented effectiveness, including personalized approaches, treatment de-escalations, and not to forget the role and benefit of the neoadjuvant approach in HER2-positive breast cancer. Let's start with talking about stage 1 HER2-positive breast cancer. How low should we go? So the APT trial was a single-arm phase 2 study for patients with node-negative HER2-positive tumors that are up to 3 centimeters in size. Patients received 12 weeks of paclitaxel with trastuzumab, followed by 9 months of trastuzumab monotherapy. The study demonstrated very few recurrences with a 7-year disease-free survival of 93.3% and a 7-year recurrence-free interval of 97.5%. And while this was just a single-arm trial, because of the outstanding efficacy seen, international guidelines now recommend paclitaxel trastuzumab for stage 1 HER2-positive tumors. Then the question came, could we have even lower toxicity approaches for stage 1 disease? So the Attempt trial looked to see if TDM1 could be an alternative approach to trastuzumab paclitaxel. And this study randomized patients with stage 1 disease in a 3-to-1 fashion to 1 year of TDM1 versus the TH regimen. The study demonstrated that TDM1 was associated with a 3-year disease-free survival of 97.7% with just 2 recurrences. Overall, TDM1 was associated with excellent outcomes. However, there were not much differences in clinically relevant toxicities between the 2 arms. But there were differences in the type of toxicities that were seen. For example, neurotoxicities among patients who received paclitaxel were higher than the patients who received TDM1. Additionally, there was more febrile neutropenia and alopecia in the paclitaxel arm. Therefore, TDM1 could be a reasonable approach for those patients who are concerned of the paclitaxel Herceptin toxicity, such as neuropathy, neutropenia, and alopecia. So let's talk about another case. Mrs. L. She is a 43-year-old woman who had 2.2 centimeter ERPR negative, HER2 positive breast cancer with 2 positive axillary lymph nodes. She was very anxious about her new diagnosis and asked few whether she will be getting surgery soon. So what would be the next step for Mrs. L? Let's move on to stage 2 and 3 HER2 positive breast cancer. We'll start off talking about pertuzumab. The original data came from the neoadjuvant setting, where adding pertuzumab improved pathological complete response, specifically in the setting of multi-agent chemotherapy, TCHP, which showed a pathological complete response of about 60%. This data, in addition to the large phase 3 adjuvant trial Affinity, which is on the most recent update in 2019, showed a 4.5% absolute difference in IDFS with adding pertuzumab in the lymph node positive patients, regardless of hormone receptor status, confirming that pertuzumab should be added as part of standard of care, especially in lymph node positive disease. Moving on to the next drug in the adjuvant setting, which is TDM1. Now we know that neoadjuvant therapy is very important in stage 2 and 3 HER2 positive disease, as it helps us risk stratify patients and optimize treatment in patients who do not achieve pathological complete response since they have worse outcomes. This is where the Catherine trial led to practice-changing results. Patients who were switched to TDM1 in the adjuvant setting had about 10% improvement in invasive disease-free survival compared to just trastuzumab. And now our practice includes switching to TDM1 in any residual disease after neoadjuvant approach. Important to know, though, that there were no differences in CNS events between both arms. This remains an unmet clinical need to find strategies to reduce CNS recurrence in HER2 positive breast cancer. So back to Mrs. L. She agreed to neoadjuvant systemic therapy approach and completed 6 cycles of TCHP and then proceeded to surgery. Surgical pathology showed 7 millimeter invasive cancer consistent with residual disease. So what do you think is next for Mrs. L? No additional therapy needed. Would you continue her Herceptin and pertuzumab to complete 1 year, or would you switch to TDM1 in the adjuvant setting for a total of 14 cycles? Wonderful. So most of you got this answer correct. So this patient has residual disease, and as we saw from the Catherine study, switching to TDM1 does improve survival compared to just continuing her Herceptin and pertuzumab in the adjuvant setting. Moving on to the last adjuvant drug here, neratinib. So neratinib was approved based on the ExoNet study, where patients received adjuvant neratinib for 1 year after completing adjuvant standard therapy. This was compared to placebo. The study showed an absolute invasive disease-free survival improvement of 4.4% but specifically in the hormone-positive subgroup. However, we still don't know the value of this drug, both pertuzumab or TDM1. Additionally, there is grade 3 diarrhea seen in 40% of these patients. So neratinib hasn't been a very popular drug, but it could be an option in very select group of high-risk patients who are both hormone-positive and HER2-positive breast cancer. So let's move on to de-escalation strategies in early-stage HER2-positive breast cancer. One of the most important updates that I would like to mention is the TRAIN2 study that looked at whether we can omit anthracycline from the chemotherapy backbone in stage 2 and 3 HER2-positive patients. This was an important study because both anti-HER2 and anthracycline can cause cardiotoxicity, and combining both drugs can have an additive cardiotoxic effect. So as we see here in the Kaplan-Meier curve on the right, there were no differences between the anthracycline and no anthracycline chemotherapy groups, and there were no differences in pathological complete response rate. However, in the anthracycline group, we had more cardiotoxicity and we had a higher risk of new malignancies. As a result of this study, now we rarely use the combination of anthracycline and anti-HER2 therapy in early-stage HER2-positive breast cancer. There are more efforts being made to de-escalate therapy in HER2-positive disease, one of which is the ongoing COMPASS HER2 trials. In this trial, patients received THP, so 1 chemo, 2 anti-HER2, for 4 cycles in the neoadjuvant setting, and if they achieved pathological complete response, they would complete 1 year of Herceptin and pertuzumab. So this is a strategy to decrease the amount of chemotherapy we give to patients who achieve pathological complete response. On the other hand, if the patients do not achieve PCR, a second part of the trial is assessing whether adding tucatinib to standard of care TDM1 in the adjuvant setting could benefit these patients. So to summarize treatment algorithm in early stage HER2-positive breast cancer, so in tumors less than or equal to 2 centimeter, clinically node negative, we usually proceed to surgery first. And then in the adjuvant setting, if the patient was stage 1, we give them paclitaxel plus Herceptin versus TDM1 in select group of patients. And in stage 2 or 3 disease, we give them adjuvant TCHP. If a tumor is more than 2 centimeter or clinically node positive, our approach to proceed with neoadjuvant chemotherapy, usually TCHP, proceeded with surgery, and then depending on what we find at surgery, whether they have pathological complete response, they receive Herceptin plus pertuzumab for 1 year, versus if they have no pathological complete response, we give them TDM1 for 14 cycles based on the Catherine study. And then you may consider neratinib in the hormone-positive high-risk subgroups. Moving on to metastatic HER2-positive breast cancer. So we are all familiar with the Cleopatra study, which showed that adding pertuzumab, docetaxel, and Herceptin improved overall survival by about 16 months in the first-line setting. In the second-line setting, the Emilia trial showed improved overall survival when using TDM1 versus lapatinib capecitabine in the second-line setting. As of 2018, our management for metastatic HER2-positive breast cancer consisted of THP in the first-line setting, followed by TDM1 in the second-line setting. Then in the third line or beyond, it was a take-your-pick strategy between lapatinib-based regimens or trastuzumab chemo. This has significantly changed only in the last 3 years, with several new approvals in this setting, such as trastuzumab deruxtecan and tucatinib. Let's start off with trastuzumab deruxtecan. This is an antibody drug conjugate with a topoisomerase 1 inhibitor payload. DESTINY-Breast01 evaluated this drug in heavily pretreated patients with a median of 6 prior lines of therapy. On the left, we see a confirmed overall response rate of about 60% in these patients. And on the right, we see a median progression-free survival of about 16.4 months, which is quite impressive compared to historical data of a median progression-free survival of 3 to 6 months in third line or beyond. Interstitial lung disease was noted in about 14% of patients, They were mostly grade 1 or 2. However, there were 4 reported deaths associated with this toxicity. It can be reversible in about 50% of patients as seen in the trial, and usually patients are treated with dose reductions and steroids, depending on their grade. So to summarize, this is a very active drug in pretreated HER2-positive metastatic breast cancer patients. However, the interstitial lung disease risk is worrisome. And on December 20, 2019, the FDA granted accelerated approval to trastuzumab deruxtecan for patients who had 2 or more lines of therapy. Moving on to the next new exciting agent, tucatinib, which is an oral HER2-selective TKI, and HER2CLIMB evaluated tucatinib, trastuzumab, and capecitabine versus trastuzumab and capecitabine in pretreated patients. Important to note that in this trial, 48% of the patients enrolled had brain metastases. In the overall population, we see an improvement in progression-free survival and overall survival in the tucatinib arms. And based on this data, FDA approved tucatinib in patients with HER2-positive metastatic breast cancer in April 2020. Importantly, we saw an impressive improvement in progression-free survival and overall survival for patients with active brain metastases who were randomized to the tucatinib arm. And this is really the first randomized clinical trial to report a TKI leading to prolonged overall survival in patients with HER2-positive metastatic breast cancer and brain metastases. Moving on to margetuximab, and briefly the Sophia trial, where they evaluated margetuximab plus chemo versus trastuzumab chemo in pretreated metastatic HER2-positive patients. As you see here, there was a small improvement in progression-free survival, and overall survival data remains immature. There is some exploratory analysis showing enhancement of the drug benefit for lower affinity FV and FS genotypes, but the clinical applicability of this remains unclear. On December 16, 2020, FDA approved margetuximab plus chemo for HER2-positive patients who had 2 or more prior lines of therapy. So our current management algorithm in 2021 has changed drastically. The THP remains in the first-line setting, TDM1 remains in the second-line setting, but now we have a choice of tucatinib, trastuzumab, capecitabine, or trastuzumab deruxtecan in the third and fourth-line settings. And in terms of which sequence to use in the third or fourth line will depend on the status of the intracranial disease, extracranial disease burden, patient comorbidities, and toxicities. The take-your-pick option, which was previously a third-line option, has now moved to fifth-line and beyond. And there's still a question here of what's the role of lapatinib or neratinib-based regimens post-tucatinib. There are also many new agents and combinations in development for HER2-positive disease, and we're excited to see more data from these trials in the near future. Lastly, I wanted to share with you this pretty exciting immunotherapy trial for HER2-positive patients. We know that CAR T-cell therapies have shown success in numerous hematologic malignancies. However, in solid tumors, it remains a major challenge. This is a phase 1 first-in-human study of adenovirally transfused macrophages engineered to contain an anti-HER2 CAR for HER2-expressing solid tumors, including heavily pretreated HER2-positive breast cancer. So basically, these engineered myeloid cells are trafficked to the tumor, reduce the tumor burden, reprogram the tumor microenvironment to induce an anti-tumor adaptive immune response. This is a pretty exciting study that is actively recruiting at UNC and at UPenn, and we are awaiting results hopefully soon. So moving to the last but not least topic of finding the positive in triple-negative breast cancer. So this is our last case of Mrs. M. Mrs. M is a 57-year-old woman who was diagnosed with 3.2 centimeter triple-negative breast cancer with no palpable lymph nodes. She got neoadjuvant ACT, she got neoadjuvant dose-dense AC followed by carbotaxol, and then she elected for bilateral mastectomy. And after surgery, she was found to have pathological complete response. Unfortunately, 8 months later, she presented with nausea and abdominal pain, and on PET-CT, she was found to have multiple liver metastases. Biopsy of the liver lesion confirmed metastatic breast cancer, which was also triple negative, PD-L1 negative, and had no actionable mutations detected. The patient was started on capecitabine with partial radiographic response. However, she had a hard time with diarrhea and rash. She had a CT chest abdomen pelvis after 6 months on capecitabine, which showed progression with several new liver lesions and multiple new pulmonary nodules concerning for lung metastasis. Patient is tired of chemo, and she's asking for out-of-the-box treatment options that doesn't involve conventional chemotherapy. So what option would you recommend for Mrs. M? Would you discuss starting atezolizumab or pembrolizumab despite her negative PD-L1? Would you discuss an antibody drug conjugate, particularly sacituzumab govitecan, which is approved in the second-line or beyond setting? Or would you tell her she has no other targetable mutations, so traditional chemo is probably her next step? Wonderful. You did very well. I don't think you need me here.
Dr.
All right.
Abdou, I apologize for the interruption. I just want to let our audience know that I'll go ahead and open the questions poll in just a few seconds. So if you do have questions out there, you can go ahead and go to Poll Everywhere and start submitting those now. Thank you.
Perfect. All right, I will answer this question as we move along, talking about triple-negative breast cancer. So research advancement has provided novel insights to clinical and molecular complexity of triple-negative breast cancer. More recently, the molecular and biological features are emerging as possible actionable targets for treatment of this disease. And today we're going to talk about some of the newer exciting therapies in this subtype of breast cancer. Let's start with the role of antibody drug conjugates in triple-negative breast cancer. Trope2 is an epithelial antigen expressed on many solid tumors, including triple-negative breast cancer. In a meta-analysis, Trope2 overexpression was significantly associated with poor overall and disease-free survival across multiple tumor types. Sacituzumab govitecan is an antibody drug conjugate that targets Trope2 with an SN38 payload. SN38 is an active metabolite of irinotecan with 1,000 times more activity than irinotecan itself. So the Ascent trial was a phase 3 trial which enrolled over 500 patients with metastatic triple-negative breast cancer who had received at least 2 prior therapies for metastatic disease. In the trial, patients were randomized to receive either sacituzumab govitecan or physician's choice of chemotherapy. The primary endpoint of the trial was progression-free survival, and secondary endpoints included overall survival and overall response rate. The study demonstrated a statistically significant improvement in progression-free survival from 1.7 to 5.6 months in the SASI arms, and a significant improvement in overall survival from 6.7 to 12.1 months in the SASI arms. Overall, sacituzumab govitecan was well tolerated with no treatment-related deaths. The most common grade 3 to 4 adverse events in the sacituzumab arm included neutropenia, anemia, and diarrhea. Based on this data, on April 7, 2021, the FDA granted approval to sacituzumab govitecan for patients who had received 2 or more systemic therapies, at least one of them for metastatic disease. During ASCO 2021, Lisa Carey and colleagues presented the sub-analysis from the ASCENT study, looking at safety and efficacy outcomes in patients who had disease recurrence within 12 months of completing their neo or adjuvant chemotherapy and received only 1 regimen in the metastatic setting. Just to remind everyone, this is a drug approved after 2 or more lines of therapy in the metastatic setting. So in this subgroup of patients, we saw improvement in progression-free survival from 1.5 to 5.7 months in the sacituzumab arm, which was very similar to the primary analysis in the overall population. Similarly, we see doubling in overall survival from 4.9 to 10.9 months in the sacituzumab arm. This sub-analysis concluded that sacituzumab govitecan is efficacious in patients with early relapse to chemo and supports that this drug can be used in a second-line setting for metastatic triple-negative breast cancer. So back to our 57-year-old patient who recurred within 8 months of neoadjuvant chemo and progressed after first-line capecitabine. So you guys did great. Sacituzumab can be offered in the second-line setting and is a reasonable option for this lady given this recent sub-analysis. There are several ongoing studies with sacituzumab govitecan in localized and metastatic triple-negative breast cancer that will probably have results in the next few years. Moving on to Daphoduroxycan, it's a new Trope-2 antibody-drug conjugate that has a topoisomerase 1 inhibitor payload similar to sacituzumab govitecan. This has been tested in metastatic triple-negative breast cancer cohort and results presented at ESMO Breast this year. Anti-tumor activity was pretty impressive with an overall response rate of 43% and a disease control rate of 95%. This drug also demonstrated manageable safety profile with no treatment-related discontinuation, confirming that Trop-2 antibody-drug conjugates are really here to stay in triple-negative breast cancer, and we look forward to future studies using these agents. There are many more antibody-drug conjugates against different targets that are being developed in metastatic triple-negative breast cancer, which we will not have time to cover today, but we are anticipating results soon. Moving on to the role of immunotherapy in triple-negative breast cancer. We know triple-negative breast cancer, out of the other subtypes, is the best candidate for immunotherapy due to its higher tumor mutational burden, the higher presence of tumor-infiltrating lymphocytes, and higher rates of PD-L1 expression. In the metastatic setting, the iconic trial for immune checkpoint inhibitor in triple-negative breast cancer is IMpassion130 trial, where patients with metastatic triple-negative breast cancer were randomized in the first-line setting to nab-paclitaxel with or without atezolizumab. The final overall survival analysis was presented at ESMO last year, showing a clinically meaningful extension of 7.5 months with atezolizumab nab-paclitaxel versus placebo in the PD-L1 positive patients. The overall survival data in the overall population remained non-statistically significant. And we know in March 2019, the FDA approved atezolizumab for PD-L1 positive metastatic triple-negative breast cancer patients in the first-line setting. Similarly, Keynote 355, this is a study that looked at pembrolizumab plus chemotherapy in the metastatic setting. Here we had more chemotherapy options, including nab-paclitaxel, paclitaxel, or gemcitabine carboplatin. Again, we saw that pembro and chemotherapy significantly improved progression-free survival versus chemotherapy alone in patients with a combined positive score of greater than or equal to 10 on the right-hand side. The other cohorts were not statistically significant per pre-specified p-values. The overall survival data is still immature. Based on this data, on November 13, 2020, the FDA granted accelerated approval to pembrolizumab in combination with chemotherapy for metastatic triple-negative breast cancer patients whose tumor expressed PD-L1 with a CPS of greater than or equal to 10. This stands in contrast to what we saw in IMpassion131. This was a phase 3 trial in which patients with the same eligibility as IMpassion130 were randomized to receive atezolizumab plus paclitaxel or paclitaxel plus placebo. In this trial, adding atezolizumab to paclitaxel did not improve progression-free survival in the PD-L1 positive population, and given this negative finding, the intent to treat population was not formally tested. And based on this, on September 8, 2020, the FDA issued an alert about efficacy and potential safety concerns with atezolizumab in combination with paclitaxel for treatment of breast cancer patients. So what about immunotherapy in the early triple-negative breast cancer setting? Several trials looked at immune checkpoint inhibitors in early triple-negative breast cancer, most of which showed improved pathological complete response when we add immune checkpoint inhibitors to chemotherapy. But the question is, does this pathological complete response benefit with immune checkpoint inhibitors really translate into a survival benefit? The Keynote 522 study looked at pembro plus chemo in the neoadjuvant setting, showed improvement in event-free survival with pembrolizumab at interim analysis A2 and A3. However, this was still not statistically significant for a pre-specified p-value at the time of FDA submission. However, on May 13, 2021, Merck did announce that the KEYNOTE-522 trial met its dual primary endpoint of event-free survival, and we are currently awaiting for FDA approval. Additionally, updated results from the GAPAR and WAVO were presented at ASCO 2021, and as a reminder, this is in early triple-negative breast cancer patients who had durvalumab induction followed by durvalumab chemotherapy in the neoadjuvant setting compared to placebo plus chemotherapy. And here the updated findings showed that PD-L1 inhibitors significantly improved long-term survival outcomes in these patients, including invasive disease-free survival, distant disease-free survival, and overall survival. Several questions remain, however. We would like to know what are the biomarkers to identify optimal responders in the neoadjuvant setting, and do we really need all that much chemo in every patient, or can we have some de-escalation strategies? And what's the role of adjuvant immune checkpoint inhibitors, and if so, for how long? And there are other questions about long-term benefit and safety data, which is still immature. Now we will move to the last part of our lecture, which is PARP inhibitors in triple-negative breast cancer. In the metastatic setting, we have two FDA-approved PARP inhibitors, olaparib and talazoparib, for patients with germline BRCA mutations based on their improvement in progression-free survival. There is also exciting data looking to identify patients beyond germline BRCA 1 or 2 mutation carriers who may benefit from therapies like PARP inhibitors. As you see, it looks like patients with germline PALP2 mutations appear to benefit as well, and further studies are being done to investigate this finding. Moving to the early stage setting, the hottest update here from ASCO plenary session a few weeks ago where the Olympia results were presented, and this is a phase 3 study of adjuvant olaparib in high-risk early HER2-negative breast cancer with germline BRCA mutation. Eligible patients are HER2-negative with germline BRCA 1 or 2 who were stage 2 or 3 up front or who did not achieve pathological complete response post-neoadjuvant chemotherapy. These patients were given PARP inhibitor, specifically olaparib, versus placebo for 1 year in the adjuvant setting after completion of all their standard therapy. As you see, we see a significantly improved IDFS in the olaparib arm with a hazard ratio of 0.61. In addition to improvement in invasive disease-free survival and distant disease-free survival, there were really no new safety concerns, and the results were really practice-changing. This brings us to the point that upfront genetic testing is really important now to make treatment decisions moving forward. So to summarize, immunotherapy is now standard in PD-L1 positive metastatic triple-negative breast cancer, and we have 2 approved checkpoint inhibitors combined with chemotherapy, pembrolizumab and atezolizumab. Immunotherapy in the neoadjuvant setting is not yet approved, but very close. Daphoduroxycan govitecan is a new treatment option for triple-negative breast cancer patients, second line or beyond, and there are many other antibody drug conjugates in development. PARP inhibitors appear to be active in patients with germline PALP2 mutations, and PARP inhibitors in the adjuvant setting will soon be standard of care for high-risk early-stage HER2-negative breast cancer patients with BRCA mutations. So are we starting to make a difference in triple-negative breast cancer? I would argue yes. We have improved multidisciplinary care and better surgical and long-term outcomes for early-stage triple-negative breast cancer. We have improvements in medical management, so we are beginning to bend the curve in metastatic triple-negative breast cancer. We have better understanding of the triple-negative breast cancer biology, which is very important in finding targets for treatment and eliminating the term triple-negative breast cancer. I hope I was able to convince you to be a little positive about triple-negative breast cancer. I would like to thank my colleagues who shared their expertise and slides with me, and I would like to thank my patients who inspire me every single day. Thank you all for listening, and I'm happy to take any questions.
All right. And Dr. Abdou, this is phenomenal. Thank you so much. And we do have several questions, so I'll keep putting those up as you have time to address those.
Sure. So, Tim, would you like me to read the questions out loud or?
I think that would be helpful. That would be great. Thank you.
So, one person asked that the patient in case 1 had 1 out of 2 sentinel lymph nodes positive, and we say these patients with 1 to 3 lymph nodes get hormonal therapy only with low or intermediate oncotype DX, but the patient only had 2 sentinel lymph nodes removed and no completion axillary dissection. So how do we know if she had basically more positive lymph nodes? That's a great question. I wish I had my surgical and radiation oncology colleagues to comment on this, but basically there have been trials showing that if you have 1 to 3 positive lymph nodes, you do not have, if you don't have more than 3 positive lymph nodes, you can omit axillary dissection and just offer adjuvant radiation therapy, and they found similar outcomes in these patients. So there's a specific criteria that that they follow, that our surgical colleagues follow to basically omit an axillary dissection in certain patients. And it's a V11 criteria in that setting. So this patient did really get standard of care management. Next question, how would you treat an active premenopausal 49-year-old, HER2 positive, ER sample destroyed, 2 centimeters, invasive, but LCIS with clean margins, node negative with no comorbidities? So she is HER2 positive. If she's HER2 positive, she definitely needs anti-HER2 treatment. And since she's 2 centimeter, I would recommend neoadjuvant anti-HER2 with chemotherapy. So right now, the standard of care is TCHP versus enrollment in a clinical trial of de-escalation like THP, and proceeding to surgery afterwards. And then depending on the pathological complete response, if she had no residual disease, she will continue HP for a whole year. If she did have residual disease, she would switch to DDM1 at that time. In your opinion, what do you think is the leading cause of breast cancer? That is a very difficult question, I would say. I don't think there is a leading cause of breast cancer. I think there are many risk factors for breast cancer, in addition to family history and genetics. There are other hormonal risk factors that contribute to hormone-positive breast cancer subtypes. There are other environmental risk factors. There is radiation in patients who have had past malignancies and radiation to the chest. There's denser breasts have higher risk of malignancies. There are several causes of breast cancer, environmental, demographic, and genetic. But I do know that we are the screening mechanisms that we have in place are helping us to detect more breast cancers and helping us to treat them pretty early. So I'm an advocate for screening, for following the screening guidelines pretty aggressively. Have you seen any improvements in managing side effects such as peripheral neuropathy of chemotherapy? So there are a lot of ongoing studies to help with peripheral neuropathy in chemotherapy. I do recommend in my clinic for patients to use cryotherapy, which is basically they wear gloves and booties where they were iced before they received the chemotherapy. So the idea is to constrict the blood vessels in your fingertips and toes to avoid the chemotherapy going to those smaller blood vessels in those areas, and hence avoiding the toxicities. And I've seen a few patients who actually benefited from that approach and has had less neurotoxicity and less dose reduction. Moving on to the next question, do you incorporate exercise, massage therapy, or nutrition counseling as part of your care plan team? Of course. I think it's pretty important, especially in our survivorship patients. We have data that obesity does increase your risk of breast cancer. So I do recommend patients to continue exercising, continue eating healthy, and massage therapy never hurts anyone. So I do recommend any form of self-care in that regard. So moving on to the next question. Do we have time, Tim? One last question.
Yes, we do. Let's make this the last one. We actually have more, but I think we're running out of time.
All right. So what is your current approach to adjuvant systemic therapy for node positive, perhaps just one node, premenopausal ER positive, HER2 negative breast cancer? Do you send genomic assay at all or defer and move to chemotherapy? That is an excellent question. And I think we still are, we're lacking data. So the RX Ponder data actually surprised a lot of us with regards to the premenopausal cohort, because those patients benefited from chemotherapy in that trial, regardless of what their risk score was, even in patients with low risk scores of 0 to 11. So right now, my practice incorporates discussing this data with my patients. I tell them that prior studies have shown benefit in premenopausal patients when we use chemotherapy, and I do recommend it. Now, whether the patients actually got benefit from the chemotherapy itself or from the ovarian suppression associated with the chemotherapy is still unknown, and I think further studies are needed to sort of clarify that aspect. But at this time, with no other data, I think we should offer chemotherapy to those patients just based on the RX Ponder data showing that they really benefited from chemo regardless of what their genomic assay is. And if the patient was really hesitant to receive chemotherapy, I would at least offer her ovarian suppression plus endocrine therapy to offer more benefit in that regard.
All right, and I'm sorry to our audience that we don't have time for Dr. Abdou to answer all of your questions. Dr. Abdou, thank you so much. This has been wonderful. Would you mind going ahead and advancing to that next slide? We'll quickly wrap up with a few important messages. First off, we want to thank the people of North Carolina for supporting the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank our team, Mary King, Veneranda Obore, John Powell, Aaron Schmidt, for all of their hard work on this.